and the unusual. Over to you, Parth.
Thank you, and I would like to thank the scientific committee for inviting us here. My topic is on preoperative measurements to get perfect outcomes, the usual and the unusual. And I would acknowledge Dr. Purnima's contributions for this presentation as well. No financial interest. This is one of our patients, 61-year-old with rheumatoid arthritis, with a Schirmer's of 1 millimeter and a very significant ocular surface disease. And patients like these definitely affect your preoperative measurements. And there's a slight story behind this patient. He was also a biochemist, and he had a history of undergoing PI. Also complained of dry eyes, and he said, "Doctor, whenever I cry, I don't get tears." And I said, "Why is that?" And he said, "I've been married for 25 years. I said, "I can understand, I've been married for 14. But this patient finally did get a punctal plug, and we were able to get fairly good keratometry results and then planned for surgery. As you can see, a post plug patient. The other patient, one other example, a 31-year-old lady unhappy with vision, underwent IOL surgery about 10 years back. And of course, an important point in history was the husband was a local councillor and was not very keen on surgical intervention. And we did find that the lens was actually placed in the sulcus, and on further testing we did find that this patient actually was a nano-ophthalmic with an axial length of about 16 in both eyes, with fairly steep corneas. And for her, we had to actually do a fair bit of planning in terms of removing the first eye. Could you reduce the volume? Reduce the volume. Switch it off. So we actually dissected the anterior and the posterior capsule. And since we didn't know the IOL power for this patient, we did a bit of calculation in terms of removal of the first IOL and implantation of the second, and we put the planned IOL in the bag and then reinserted the first IOL, and we were actually fairly pleasantly surprised that we had a fairly good post-operative result. And this was one other patient that our optometry was actually able to get good results. Now, in getting perfect results, I think there is no longer any utopia. It's fairly common to get good vision if you've done your planning, like this patient who was in our OPD about a week back with uncorrected 6x6 N6 post-surgery. Of course, there are some critical factors in achieving perfect outcomes in the present era, where you have good repeatable measurements for keratometry, axial length, and that is probably one bugbear which we've actually not been able to crack, is effective lens position, because that is almost a variable component, varies with patient systemic factors, and occasional capsular phimosis, like in this patient who had uncontrolled diabetes, came back with a very significant refractive surprise a month later, and we had to actually go and reopen the tunnel and then release the phimosis, and his refractive error then came back. Keratometry and axial length in terms of patient cooperation are probably more important for optical biometers than for the standard biometers. In terms of keratometry measurement, which is important in what I call normal virgin corneas, there is actually fairly good agreement between IOL master, IOL 500, 700, even Scheimpflug imaging, which is considered the gold standard for keratometric measurements, vis-a-vis the prominent measurements of K1, K2, the mean K, and astigmatic measurements. Very occasionally you do need to take into account posterior corneal measurements, but that is more probably for abnormal corneas. When you get the total corneal power, which is now probably available with the Barrett's, your requirement for having additional measurements is less critical. Another study which did say there's no clinical significant difference between almost all these measurements with respect to axial length, mean K, and antechamber depth. And this is important because now you can get repeatable measurements with which is fairly independent of the person doing it, and that is important when you do not have the time to do these measurements for each and every patient that you have. There is also a good study which mentioned that there is high comparability between almost all machines which are now available, including the newer ones like the Cassini in normal virgin cornea. So we have sorted that out in terms of what is required for keratometry measurements. However, there is now fairly good evidence, not much though, on trying to solve the conundrum with complex corneas. It is known that diseases that alter the posterior corneal curvature, like ectasia, post-refractive surgery, do have slight errors in measurement because the concept of measurement for these machines are not good. And you need to then look at the total true corneal power, which occasionally, if not measured properly, gives erroneous results in calculating the IO power. In fact, even in Scheimpflug measurements, the SIMK tends to overestimate the total corneal refractive power, especially in advanced keratoconus, and this discrepancy proves to be a source of hyperopic refractive error after surgery. In this patient who we operated and is post-RK, you can make out in the red glow, we did do multiple measurements before we actually went ahead with the surgery, and you need to confirm this across at least 2 or 3 machines, and this is an important area where you can get slight discrepancies. A commonly asked question is, do you actually need an optical biometer? And almost 95% of probably Indian ophthalmologists who practice do not use optical biometers as routine. And it is now fairly well proven that immersion biometry gives comparable results to optical biometry and gives predictable results if you have the input data in terms of K1, K2 fairly confirmed. There are of course newer machines which have an all-in-one biometer which gives reliable and reproducible measurements across the factors of K, axial length and anterior chamber depth, and most of them now also give white to white, and maybe for probably challenging cataract surgeries, unusual high myopes, post-refractive surgery, even for that post-keratoplasties, it may be a worthwhile investment if your volume of practice for those kind of corneas are more. Of course, there are some advantages in terms of non-contact, shorter wavelength, which measures the axial length more precisely, and scans along the visual axis. This is important when you have patients with staphyloma, which can be a source of undercorrection. Also important that ultrasound biometry measures only till the interlimiting membrane, and the additional 200 microns with the optical biometer may be a small source of error as well. Remember, this is not affected by IOL material in surifix or fake silicon oil. Is there a difference between technology of what is not commonly used, which is a partial coherence interferometry, compared to the swept source? Probably for majority of the cataracts which are early, it may not really make a big difference. But for advanced cataracts where you need to make sure that you have good penetration, it is the partial PCI based optical biometer may not be ideal because it is unable to measure axial lengths in dense or diffuse subcapsular cataracts. And in fact, there has been one study which mentioned that the failure rates are almost close to 30+%. The present new kid on the block of swept source based optical biometers, which is SSOCT, seems to have slightly better results. There are only, as far as I know, 2 Indian markets, 2 machines in the Indian market, and both seem to have fairly good penetration in grade 4, even 5 cataracts. This is also an important part because it can confirm the line of the scan occasionally through the fovea, and this does give significant advantages in slightly difficult eyes. In terms of IOL power, which is an important part of measuring your preoperative plan, I think generation 1 and generation 2 IOL formulas are no longer preferable. I think the generation 3, and if you have access, generation 4, and a lot of these formulas are now available online and free of cost, which are probably more accurate for majority of the cases. In fact, I think the present predictability as per studies is more than 90+% if you've got the keratometry, the axial length measurements, and the IOL power correction done. This is a fairly recent slide, and this has changed over the last maybe 10 to 15 years in terms of the accuracy range for commonly used formulas by axial length. And in fact, if you look at accuracy across short, normal, and long axial lengths, I think the Hill RBF and Barrett's True K are actually preferred, probably now the present gold standard, and that's something that I would definitely recommend. A couple of points about cataract surgery and endothelial disease, which can definitely affect your surgical plan, since I do have a fairly large cornea practice, and this was a patient with Fuchs dystrophy, and you can make out the endothelial guttate, and when you're actually combining these with endothelial keratoplasty, remember that you would definitely need to probably overcorrect by about a diopter and a half. In conclusion, there are multiple factors that affect outcomes. Repeatable measurements to ensure good visual outcomes in the normal range of K and axial length is now fairly predictable. Unusual corneal topography can definitely affect calculations and needs to be confirmed on devices with more data measurements, especially for patients post-keratoplasty, keratoconus or intracorneal rings. Coexisting morbidities definitely require adjustments of the technique, and I thank you for the attention.
Thank you, Dr. Anand, for that